Good morning, everyone. We'll get started for the Satellite Symposium. My name is Mark. I'm one of the hematologists in Ottawa. And it's a great pleasure to be here today with my co-chair, Dr. Shiva Kumar from Halifax, to discuss the controversial topic, cancer-associated thrombosis. And we'll go through different cases that are challenging and try to gather your thoughts on how to manage these patients specifically, and hopefully we'll be able to generate a good discussions. For our online participants, please use the Q&A feature for questions and comments, and Sudeep will be monitoring them, so we'll ask the questions at the end of the presentation. So this is an accredited program, and I'm presenting you the scientific committee. Dr. Cynthia Wu was the chair of the program, and Sudeep and I were participating, so we're helping with the different cases. And it's important to have a look at the scientific committee disclosures. And it's also important to disclose commercial support. So this program has received educational and in-kind support from Pfizer Canada. And as you're probably aware, Pfizer Canada may benefit from sales of products that will be discussed in the program, and that will be dalteparin or Fragmin or Apixaban or Eliquis. But of course, we did everything we could to mitigate bias, and this program has been accredited by the College of Family Physicians of Canada, by the Royal College of Physicians and Surgeons of Canada, and by the Canadian Council on Continuing Education in Pharmacy. So these are my disclosures. So as you may have heard before, I deposit all my honorarium into the Ottawa Hospital Research Institute funds. They're used for educational research with colleagues, but it's important to keep in mind as they might be important conflicts to be aware of. So what we'll try to do today is to have a little bit of an overview about the epidemiology of cancer-associated thrombosis, discuss factors that can lead to changes in management. How do you tailor anticoagulation? So that could be, for example, risk factors to avoid bleeding, determine appropriate dose and type of anticoagulant, so the right anticoagulant for the right patient, especially if there's additional features like thrombocytopenia, renal function impairment, and debate the approach of managing cancer-associated thrombosis. And this particular program has a number of different cases, but because we only have about 40 minutes or so together to entertain you over breakfast, Sudeep and I will only do 2 cases, so we'll specifically focus on risk of GI bleeding, how to tailor anticoagulation accordingly, and upper extremity catheter-related deep vein thrombosis, and generate discussions afterwards. All right, so just to make sure we're all on the same foot when we start, as you know, venous thrombosis is not very common in general population. It's about 1 or 2 per 1,000. As soon as you have a cancer diagnosis, you're increasing the odds ratio by 4. And if you have a particular patient with cancer initiating chemotherapy, the odds ratio is 6.5-fold. So these risk factors are really important. And that's why in clinical practice, we see a lot of cancer-associated thrombosis, independent if we're on service on the wards or in the outpatient ambulatory care setting. Now, this was nicely illustrated by a recent Danish registry that was published in Blood last year. They identified 500,000 patients with a first cancer diagnosis, matched them with 1.5 million without a cancer diagnosis, and followed them over time over 2 decades. And the first thing they reported was that the 6-month risk of VTE in patients with cancer was 12-fold higher compared to general population, and 23-fold higher if they're ongoing chemotherapy or targeted therapy. So our patient population is really high risk. And the second thing that I find interesting that they reported is when they followed patients for 2 decades, they saw a 3-fold increased risk of VTE diagnosis and 6-fold increase if they were undergoing chemotherapy. Therefore, this is not a problem going away. We'll be faced with more and more cancer-associated venous thrombosis over time. And identifying risk factors when we see patients that may increase the underlying risk, like prior VTE, metastatic disease, different types of chemotherapy, will be important for us to make sure that we have a good understanding and we can tailor anticoagulation accordingly. Now, we all know that these venous thrombosis are not only common, but they're associated with morbidity and mortality, right? If they have a cancer-associated thrombosis, we need to start them on therapeutic dose of anticoagulation. that's associated with a higher risk of recurrence despite anticoagulation compared to the general population, higher risk of hemorrhagic complication. So the risk-benefit ratio of therapeutic anticoagulation is different in the setting of cancer-associated thrombosis. Some studies, as you know, show that arterial and venous disease can be the second leading cause of death in cancer patients. So it's really important for us to really tailor anticoagulation appropriately and have a look at the data that has been reported in order to find the right anticoagulant for the right patients. In 2003, Agnes Lee and colleagues have done a landmark trial, CLOT, and for over a decade, low-molecular weight heparin has been the standard of care or first-line therapy for cancer-associated thrombosis. And if you look at all the randomized control trials that have compared different low-molecular weight heparin and vitamin K antagonists, you can see here on your left-hand side, there's a decrease in the risk of recurrent VT despite anticoagulation by about 50% without any increased risk of major bleeding. And when you're looking at clinically relevant non-major bleeding, there's a lower risk for folks receiving low-molecular weight heparin. And therefore, clinical practice guidelines has been recommending low-molecular weight heparin. But in 2018, randomized controlled trials comparing different direct anticoagulant to low-molecular weight heparin have been published, and therefore we needed to adapt and have a strategy because it's important to tailor anticoagulation accordingly. So in 2018 was the Okusai, and then late last year there was the last trial comparing rivaroxaban to dalteparin, Castadiva, and therefore we have now 6 randomized controlled trials that are comparing different DOACs to low-molecular weight heparin. It's not the same slam dunk that we saw when we compare low-molecular weight heparin to vitamin K antagonists. You can see on the top that when you compare different DOACs to low-molecular weight heparin, there's a decrease in the underlying risk of recurrent VTE, an absolute risk that is about 3%, relative risk difference about 40%. But that may come at a higher risk of major bleeding complication, relative risk of about 30%, absolute increase about 2%. But that certainly comes with an increased risk of clinically relevant non-major bleeding or nuisance bleeding, bleeding that people need to seek medical attention, but don't necessarily need to be in a hospital. So because the risk-benefit ratio seems to be a little bit different, then we'll need to be very mindful on who we initiate on parenteral anticoagulants and who do we initiate on oral anticoagulation for patients with cancer-associated thrombosis. And the reason why it's also important is because clots may be behaving, or anticoagulation may be behaving slightly differently in the setting of cancer. We all know that when we're talking about DVT or PEs outside of cancer, we know that the risk of major bleeding and the risk of dying, or the case fatality rate of dying from major bleeding, is higher compared to the risk of recurrent VTE. But that does not seem to be the case in patients with cancer. And again, work from Agnes Lee and colleagues have shown that the risk-benefit ratio is different, and the risk of dying from a recurrent event is higher than it's higher in cancer patients than it is for the general population. So we need to be mindful on that and try to prevent risk of recurrence as much as possible. So with that prelude, we'll look at a few different cases to try to highlight how would we manage these particular patients, and then we'll open up for discussion. So the first case is a 61-year-old male. He was diagnosed with stage 3 colon cancer 3 months ago, partial colectomy, removal of nearby lymph nodes, so resected, receiving adjuvant FOLFOX. He presents to the emergency room with acute onset left lower limb swelling, pain, erythema. He goes to the emergency room, has a compressive ultrasound, diagnosed with proximal lower limb deep vein thrombosis. His CBCs is reasonable, so he has a good hemoglobin, platelet count is good, creatinine clearance is within normal limit. The next question that the emergency room doc will probably call you for is, what do I start him on? Do I start him on a low-molecular weight heparin, or do I start him on the direct anticoagulant? So have a reflection, and we'll come back to that. Because I mentioned that if we compare the low-molecular weight heparin to direct anticoagulants, they seem to be at a slightly higher risk of major bleeding, not statistically significant, but a relative increase by 28-30%, but certainly an increase in clinically relevant non-major bleeding. So as a clinician, it's probably important to minimize potential risk factors for GI bleeding in that setting. And we all know that risk factors for GI bleeding can be categorized in different things, but just so that we can remember, we can think about tumor-related factors, treatment-related factors, comorbidities, and additional comorbidities that can lead to that. So it's important that if we identify them, we can probably try to mitigate them or try to stop or change or do something to mitigate the underlying risk of GI bleeding. And when we look specifically at patients that had major bleeding complications in the DOAC trial, well, one of the DOAC trial, the Okusai trial, compared edoxaban to low microweight heparin. When they looked at, remember that particular trial at a higher risk of major bleeding complication. When they looked at the bleeding complication in two arms, independent if they got direct anticoagulant edoxaban or dalteparin low microweight heparin, the risk in increased risk of major bleeding is not related to fatal event or to intracranial disease. It was really related to gastrointestinal type of bleeding, specifically upper gastrointestinal type of bleeding. And that's important to keep in mind, because if we have a higher risk of GI bleeding, then we may want to be mindful to use a direct anticoagulant. Now, the next question that we have is probably, well, we know patients may have a high risk of GI bleeding, but what type of patients, and can we identify a little bit the granular data? Is there other characteristic? What about the type of cancer, for example? And again, a post-hoc analysis of the Okusai VTE cancer, as published in a JTH in 2018, really stratified patients according to the underlying risk of tumor type. So is it gastrointestinal or not gastrointestinal? And you can see on the right-hand side that patients that did not have a gastrointestinal type of tumor didn't really have a high risk of bleeding if they use edoxaban compared to low microweight heparin. But on the left-hand side, if they were using edoxaban, then the hazard ratio was fourfold increase for major bleeding, most of which were upper gastrointestinal type of bleeding. So patients with gastrointestinal type of tumor, like our patient, may be at higher risk a little bit. Now, it was the same story in SELECT-D. Remember, SELECT-D compared rivaroxaban to low microweight heparin in the setting of cancer-associated thrombosis following patients for 6 months. Remember that the DSMB of SELECT-D asked investigators in 2016 to stop including patients with upper gastrointestinal type of tumors, probably because they saw an increased risk of major bleeding. And when they followed patients over time, although it was not statistically significant, they saw an excess major bleeding in patients that had gastrointestinal type of tumor. So very similar signal as what we have for Okusai VTE cancer. And that's probably part of the reason why when we read clinical practice guidelines, they say to try to be mindful about gastrointestinal type of tumors. Now, what's interesting with SELECT-D is that when you look at clinically relevant non-major bleeding, they had an increased risk in patients receiving the edoxaban, the rivaroxaban. The increased risk was 9%, absolute difference. And then when you look specifically at the tumor type, 50% of them had genitourinary type of tumors. And I think we see that clinically as well. So that's why clinical practice guidelines are saying, well, maybe be mindful about gastrointestinal or genitourinary type of tumors. Now, it was a different story with Caravaggio, right? But we need to keep in mind that Caravaggio was published 3 years afterwards, so we continued enrollment into it. When we look at Caravaggio, it showed to be non-inferior, apixaban was non-inferior to low microweight heparin, and there was no difference at all in major bleeding. And they did a post-hoc pre-specified analysis specifically for gastrointestinal type of major bleeding. There's no difference there. This is because apixaban is BID, so higher trough, lower peak, less bleeding, or is it because it's different patient characteristics? Remember, these patients with cancer-associated thrombosis have different type of malignancies, different staging, different baseline characteristics. It's hard to account for all this when we look at differences. The jury is still out, but the post-hoc analysis specifically looking at apixaban compared to low microweight heparin was somewhat reassuring. And then here we're showing specifically for a patient in a post-hoc analysis that was done by Walter Agino and colleagues, when we stratify patients with type of tumors that could be resected or not. And then you can see that when patients have tumors that cannot be resected or that's still present when they have underlying VTE, the risk of anticoagulation is high. The risk of hemorrhagic complication with anticoagulation is high, independent if they receive a direct anticoagulant or low microweight heparin. But when it's resected, the risk is low, independent of the molecule you're using. So that is very reassuring. And our patient had resection. So for this particular patient, when we go back to him, when we go back to Rodney, and we have a discussion about it, do we feel more comfortable with a direct anticoagulant or a low microweight heparin? So after seeing all this, just show of hands, who would start a direct anticoagulant? And who would start low molecular weight heparin? Some people have said nothing. You need to commit. So it's important to remember that both options are reasonable, right? Both options would provide good anticoagulation. They're both relatively safe. In this particular patient, I would feel comfortable with initiation of a direct anticoagulant because the cancer was been resected. But for example, if the cancer was not resected, and despite the fact that it's in the colon, I probably would not feel too good about initiating a direct anticoagulant. If it was upper gastrointestinal type of tumor, probably wouldn't feel so good about initiating a direct anticoagulant in that setting as well. Okay, so I'll pass things along to Dr. Shivakumar.
Well, thanks a lot, Mark, and thanks to the audience. I will present my disclosures first, and there we go. I have received some grant support and some honoraria as listed. And my case is going to be a short case, but I think a very important case on upper extremity DVT, which is something that is common and seen in patients with cancer and can be very troublesome. And it's also an area of quite a bit of uncertainty with limited evidence to guide us. So I'll go through this case with that disclaimer that we have to take the evidence that we have and adapt it to each individual patient. So Kim is a 50-year-old woman. She's previously healthy, but unfortunately she gets diagnosed with a metastatic cholangiocarcinoma. She has a PICC line inserted to receive chemotherapy, and it's placed in the right arm. However, about a week or two after having the PICC line in, she presents with swelling, discomfort, and discoloration of the right arm. I will say that on exam, her arm is swollen, and she does have dilated superficial veins over the right chest wall as well. And she goes on to have an ultrasound. The ultrasound does show DVT, an occlusive PICC-associated thrombus in the basilic, axillary, and subclavian veins. She has some baseline blood work as she will be starting anticoagulation, and her hemoglobin is slightly low, but at its baseline for the last few months. Her platelets are slightly low, but they're above 50 and above 100 even, and her creatinine clearance is adequate. So there's a couple things, and the question here is the same as the question in the first case, but just a couple things to talk about before we talk about how you're going to treat her. But I think the one thing to highlight here is this is a person who does have significant risks for venous thrombosis. We know that there's patient risks, have they had a previous clot or a family history of a clot? We know there's cancer risks. Is it metastatic or an advanced stage, or metastatic adenocarcinoma or pancreatic cancer, which may have a higher risk? And there's treatment factors. And in this case, in addition to having a metastatic carcinoma, she also has chemotherapy, which increases the risk further in cancer patients, and the PICC line, which is a provoking factor of an upper extremity DVT. The other thing I wanted to note is that this is a DVT that is in the arm, and sometimes there is, questions about whether it's a superficial vein thrombosis or a deep vein thrombosis. If it's in the forearm, distal or proximal, do you need to treat it? And in this case, I think it's a little clearer because it involves the axillo-subclavian system. And once it involves that system, we would, most certainly treat in that case because there is a risk of progression and PE. So having said that, would you initiate a direct oral anticoagulant, or would you start low molecular heparin in this patient? And I won't ask for a show of hands now, but I will at the end after we go through the case. So how common is catheter-associated thrombosis in cancer patients? And the short answer is that it is something that we see, it is common, and it's something that we have to deal with. A retrospective analysis of 158 ambulatory patients with solid tumors who had underwent a PICC line insertion, they found that 13% had a confirmed diagnosis of an upper extremity DVT. In a prospective study of 291 patients who had PICC line placement for chemotherapy, 12 patients were found to have an upper extremity DVT, 4.1%, but that's in a short period, in a 4-month period or so. So it does happen, and we do see it quite often. So what do we do in these situations in terms of treatment? Do we extrapolate from the clot trial and use low molecular heparin? Do we treat them as we would other thrombotic events with a direct oral anticoagulant? What do we do with the PICC line? And that's a very specific question to this scenario, because these patients often need the PICC line. It was placed for a reason, for ongoing chemotherapy. And taking out the PICC line, just having to have it put back in the other arm, for example, may be counterintuitive. So what is the best management strategy with respect to that? So the catheter study was a Canadian study done over 15 years ago. That was a prospective management study looking at patients with a cancer and upper extremity DVT associated with a catheter. And all patients were treated with standard venous thromboembolic disease treatment at the time, which was low molecular weight heparin. It was dalteparin 200 units per kilogram daily for 5 to 7 days, overlapped with warfarin until the INR was therapeutic, and then continued on warfarin alone with a target INR of 2 to 3 for 3 months. And the one thing that they did stipulate is that the catheter in this study could be left in if it was needed and if it was working. So, of course, if it's infected, if it's blocked, if it's not needed, it can be taken out, but otherwise the catheter is left in. And one of the outcomes was to look at catheter salvage. Can we leave the catheter in? And after a 3-month follow-up period, the results did show that there was no recurrence of VTE in any of these patients. There was no extension of the DVT, and there was no new diagnoses of PE. So from a treatment standpoint, efficacy standpoint, treating these patients as we do patients with DVTs and PEs elsewhere seemed to be very appropriate, with the caveat that this is a small pilot study, prospective, but non-randomized. There were 3 episodes of major bleeding in the study, with 1 death due to a major hemorrhage. That was a patient with a GI cancer at 22 days out from their diagnosis of the clot. And they were on warfarin alone at that point, and their INR was supratherapeutic. But overall, it was felt that the risk of bleeding, of course, is noted, but treating them with low molecular heparin overlap with warfarin seemed to be a reasonable management strategy for this population. And none of the catheters were, all the catheters were salvaged. So no catheters had to be removed because of complications. So it does appear that keeping the catheter in and starting anticoagulation is a safe management strategy. So about 4 years ago, there was a follow-up to the study called the Catheter 2 study, and again, a Canadian study involving multiple Canadian sites. And this is after the introduction of DOACs, with familiarity of DOACs and familiarity of DOACs in the cancer space. So again, it's a prospective management study of a single cohort of 70 patients with an active cancer and a new upper extremity DVT. And after diagnosis of the DVT, they were treated with rivaroxaban at standard doses for 12 weeks or 3 months. So again, looking at VTE recurrence as the efficacy outcome and safety, bleeding as a safety outcome, what they saw was, in terms of VTE recurrence, it did appear that rivaroxaban was efficacious. There was 1 episode of recurrent VTE, and the 3-month incident rate of recurrent VTE was just under 1.5%, which appeared to be, reasonable and in line and acceptable. Now, the bleeding aspect was not the same, and there actually were 11 bleeding events in 9 patients over that 3-month period, with an incidence of 12.85%. And when they broke it down, there were 7 major bleeds and 4 clinically relevant non-major bleeds. And of the major bleeds, 3 were GI, 2 were gynae, and 2 were urologic bleeds. So it does appear that rivaroxaban in this prospective cohort study that was a small number of patients seemed to work in terms of efficacy with an increased bleeding risk than we had seen in previous studies. We have some more data, and again, the data is limited, but it is helpful when we don't have, phase 3 RCT trials to look at observational studies. But this is an observational study of patients with catheter-associated upper extremity DVT in patients who have cancer, and they were looking at the outcomes of anticoagulation in these patients. It was a retrospective study, and they identified 116 patients that had a catheter-associated DVT. Of those, 99 patients were included, and the vast majority were treated with low molecular heparin and full dose for the first month. There was a handful of patients treated with warfarin and one patient treated with rivaroxaban in this study. So the majority of this data is going to reflect a low molecular heparin population. Again, in the majority of that low molecular heparin group, 89 patients, they were stepped down to an intermediate dose at 1 month. So that's a 75 to 80% dose of low molecular heparin, of dalteparin, as per the clot trial protocol. It is a bit of not controversial, but it is a varied practice, as some clinicians do continue full dose low molecular heparin through their treatment course, and some do go by the clot protocol, where they do decrease it to 75 to 80% of the dose at 1 month. And then they broke it down. They followed the patients, and there was 72 patients who did not require any further dose adjustments. There were, again, about 15 patients that had a dose reduction to a prophylactic level, like dalteparin 5,000 daily, and then a very small number that had a switch to an oral agent like warfarin or rivaroxaban. Of the patients who continued anticoagulation for at least 3 months, the majority, 80% or 80 patients, discontinued anticoagulation and were followed after that for a median of almost 2 years. So in the first 3 months of follow-up of this whole cohort, there were no recurrent VTEs, which was very reassuring. There were 2 major bleeding episodes, which again seemed to be in line with the bleeding risk from the first catheter study. And as well, they did follow patients after anticoagulation discontinuation, and there were 5 VTE recurrences that were seen. And the probability of recurrence, when they looked at the patients, was higher in those who had cancer that was active than those who had cancer that was in remission. I will also say that catheters were taken out of patients when they were no longer needed in this study or at the time of remission. So, as well, one of the questions is, can we take out a catheter safely if somebody has a blood clot? And do we have to wait a certain period of time? Do we have to wait until 3 months, or is it better to take it out early? And this is another retrospective study looking at 600 patients with catheter-associated thrombosis. The majority were treated with anticoagulation. As you see on the right, 116 patients were treated with catheter removal only. But if you look at the patients treated with anticoagulation, and we don't have details about how exactly they were treated with anticoagulation, which agent, we can see that it was a fairly close split between those who had early catheter removal at the beginning of the time of diagnosis within 48 hours, or those who had a catheter stay in or it was delayed past that 48 hours. But the bottom line of the last row there is that the risk of PE or late PE or death was very low, whether you took the catheter out early or late or left it in, giving some reassurance to doing what is right based on whether there is a need for the catheter or not. So I think the evidence, as you saw it, is not clear cut, and we have to take what we have to apply it to any specific patient. In our 50-year-old female who's diagnosed with a metastatic cholangiocarcinoma, who's receiving chemotherapy through a PICC line and develops a right arm DVT, I think we can say we would start anticoagulation. And we would attempt to leave the catheter in during treatment unless the catheter needs to be removed because of a complication like infection, or it's not working, or if it's not needed. And then the big question that comes up is, how would you treat them? with a direct oral anticoagulant or low molecular heparin. So I will throw it out to the audience to raise their hands in terms of who would treat this patient with a direct oral anticoagulant. And who would treat this patient with low molecular heparin? Okay, so there is a majority of people choosing low molecular heparin, but some people choosing direct oral anticoagulants. And I think this is a case where there is no specific right answer, and things like patient preference really come into play here. There may be needle fatigue. There may be concerns about drug interactions with their chemotherapy or supportive care medications. It may be that patient prefers an oral medication, and I think that there's room to adjust. If the patient, I always do offer that, to hear what their preference is and really incorporate that. But I will say in Nova Scotia, 80% of patients will come to me and say, well, you're the doctor, what would you do? And in this case, I would say, well, if everything is equal to you, I would recommend low molecular heparin in this case. But I know people would disagree, and that would be a good thing to discuss. And if I'd like to hear other people's views on that. So with that, to think about how the review of the evidence affected your clinical decision-making in this case. And I think we can start to take questions. Thank you for your attention. And what I'd ask is to please use the Q&A feature online if you are able to, if you have a question. And for people in the audience in real life, please come up to the microphone, and Mark and I will try to attempt to answer any questions you have. So thank you.
You can stay at the podium, so even I'll ask you all the questions.
Excellent, excellent.
So the first thing I wanted to mention, I saw Alejandro in the room. So, the London group has done CATTER 1, CATTER 2, and CATTER 3 will be presented at ASH this year as an oral presentation. So if you're at the American Society of Hematology, go and see it. And it's a different treatment strategy. And Alejandro, you let me if I'm saying anything stupid, but it's a week of low molecular heparin followed by apixaban 5 milligrams POBID for 3 months. So we'll have a bit more data related to that balance soon. So Sandeep, because you're on the podium, I get to ask all the questions.
Yes.
And I control the computer. So the first question is, if you have a patient upper extremity, but brachial vein only, so not so much proximal clot, and there's maybe some concerns about bleeding, do you always anticoagulate them, or sometimes do you not?
Yeah, so I mean, I think the location of the clot and it has always been very confusing to me because in contrary to the legs, I do find that there's a lot of different sources that say what is a deep vein in the arms versus what isn't. And the brachial vein, I would say, can be considered a forearm superficial vein, but some people would consider it a vein that needs treatment. I think for those veins that are not in the axillosubclavian system, I would go on a couple things to decide if they're going to require treatment. I think risk of bleeding, symptoms, and what their status is. Are they do they have an active cancer? Is the PICC line still in place? Is the patient undergoing chemotherapy or agents that are thrombogenic? In this specific case, I think I would lean away from anticoagulation just because of the high risk of bleeding that's noted. But I think careful follow-up and maybe even serial ultrasounds may be used in this case to help give you and the patient some confidence that we're not missing a clinically relevant thrombosis.
Thank you, Sandeep.
And there's a live question here too. Yes.
Go ahead.
Thanks, Mark and Sandeep, for the excellent presentation. I'm Ben from Toronto. I'd be interested in knowing two questions, I guess, but they're related. In all of the randomized controlled trials comparing low molecular weight heparin to the DOACs, there was a dose reduction for the clot protocol of 50% of the low molecular weight heparin, whereas the DOAC was continued at full dose throughout the treatment course. And I'm wondering, one, if you think that perhaps had an impact on the outcomes in terms of recurrent VTE in those trials. And two, what your own practice is when you're managing such patients. Thanks.
Yeah, so I can start or did you want to?
No, go right
So yes, I think with the low molecular heparin dose reduction, I think it is controversial and it was used in the study. So there is a question, at 1 month is going to a lower dose when you're still quite thrombogenic the right thing, and that was used as a standard arm in the major cancer treatment studies. But I think it is difficult to know, and we only have the data we have. I do personally use the dose reduction after 1 month, and I have not seen too many recurrences at the 1 month mark, but I know that some of my colleagues have, and they do continue the full dose throughout the treatment course. Does it reduce the generalizability of the big cancer treatment studies if you would normally use a full dose? I think potentially. How much, I think, is controversial, and I note it, but I don't really change my practice because of it. How about you, Mark?
I do the complete opposite. Just kidding. So it's a great question, Ben. So I guess when you're doing a randomized control trial, you have to use the standard of care that is approved by the FDA and Health Canada and UMA. So they didn't really have the choice but to use the dose reduction. I tend to not do the dose reduction so much, and I'll tell you why. And then Sudeep what he's been doing is fantastic too. So, although CLOT is a fantastic trial, it's from 2003. So we're going to celebrate the 20 years of CLOT soon, which makes Aggie slightly older. But things have changed since then, and we have a little bit more data in the setting of cancer-associated thrombosis. And when you look at more recent data, for example, if you look at CATCH, where there was no dose reduction for the 6-month period, sure, they saw a 35-40% relative risk reduction, but they didn't meet what they were expecting to. And then they already had the benefit for bleeding. So in my head, I'd say, well, if full dose in a comparative trial of 2015 is good, but not as good as what we were expecting, we're already getting some benefit out of the bleeding compared to vitamin K antagonists. I don't see as much as benefit to dose reduction, really. Unless the patient is high risk of bleeding, then for sure I would dose reduce, and then I take comfort in looking at the CLOT trial for that. And your point is well taken, that when you look at the trials, when you look at the KM curves, and I remember specifically the one for Okusai, the risk of recurrence seems to separate after a month or 2 months. So maybe it has something to do with increased risk of recurrence in that setting.
And I just want to say that I do the dose reduction because Mark Carrier told me to. When
that was 15 years ago.
It stuck with me. It stuck with me.
No, but I'm sure if we poll right now, 50% do dose reduction, 50% don't. And it really is based on patient's preference. Who does the dose reduction on a regular basis? Yeah, people are saying, yeah, it depends.
See?
So it depends on where you're at. Okay, so a few questions. Thank you, Ben. So Dr. Gianet online is asking, this is a question that will take a while. So how long do you treat with a DOAC and at what dose?
For cancer-associated thrombosis. Yeah. So, I mean, I think, and Mark has put out a really good treatment algorithm for cancer-associated thrombosis aimed at Canadian doctors, I believe, in current oncology that I think is very helpful. But I think the things that we know about cancer-associated thrombosis is that the risk persists as long as the cancer is active and or they're receiving treatment. So, it isn't something you can make a blanket statement about, that cancer patients get treatment forever. And you can't also go the other way and say cancer patients get 3 months of treatment and you can stop. It is a very individualized thing. So in terms of the choice of agent, I think, is that part of the question?
What dose?
What dose? Okay. So I do use full treatment dose of the DOACs as per the cancer treatment studies. So rivaroxaban 15 BID followed by for 3 weeks, followed by 20 milligrams of apixaban, 10 BID for a week, followed by 5 milligrams BID thereafter, et cetera, or dalteparin 200 units per kilogram. And then I think it is important to treat them for at least 3 months, and I tend to treat for at least 6 months. But at that point, you have to make a decision with the patient. And really, the decision is, have there been any, is based on, have there been any bleeding complications? What's their thrombogenicity? What's the status of the cancer? What treatments are they going to be receiving? And is the cancer still active? And if the cancer is active or receiving treatment, I would continue indefinitely. And then I think it is important to continue to do that same process, that same decision tree every 3 to 6 months, because if things change, the cancer is gone, they're in remission, they're not on treatment anymore, you may consider discontinuation, or if they've had a bleeding complication, that might change your calculus. But otherwise, as long as the cancer is active, I would continue to treat. Whether you can go down to a lower dose of a DOAC after 6 months is a question that we need research in, and there is an ongoing study that will look at this. But I think at this point right now, I will be continuing full dose anticoagulation and not applying any dose reductions unless there's until evidence comes out, or the odd case where there is a high risk of bleeding, and then I'm kind of just doing an empiric reduction, not based on evidence. So I try not to do that.
I would have a similar approach, Steve, as you nicely highlighted. There's 5 pieces of information that one can use to decide on dosing for standard prevention. There's 2 single-arm cohort studies, one with dalteparin, one with tinzaparin, Deltacan, and TCAT, following patients for 12 months. The risk of bleeding in the second 6 months was similar to the first 6 months. Still a high risk of recurrence despite anticoagulation. So indirect evidence saying that they probably should follow something. And then we have the second randomization of the SELECT-B, right, that randomized patients with index P or residual vein obstruction at 6 months to rivaroxaban or nothing, showing a benefit of rivaroxaban full dose after 6 months of anticoagulation. And then we have STEPCAT from Dr. Tagalakis in the room, looking at low microrate heparin, but at a dose reduction, prophylactic dosing with enoxaparin. So that seemed to be associated with reasonable risk of recurrence. And then recently, the apixaban cohort study from the Nordic countries at 2.5. So you actually have a little bit of data favoring both, but more data for probably favoring therapeutic dosing. So until EPICAT and EVE studies randomizing patients after 6 months to PIX 2.5 or 5 BID, that will be very helpful. But we just learned that EPICAT needs to continue recruitment for an additional year. So we won't have results until 2025, probably, before we can make treatment decision based on that. Okay, and then another hard question for you, because it came up twice. So if you have a cancer patient with a distal DVT or a subsegmental PE, you would treat them, probably?
Mm-hmm. Yes.
But for how long?
Yeah, no, it's a good question, and I think we have more evidence to back up specifically subsegmental PE. They seem to have a similar risk of progression to a more proximal PE as larger PEs, and especially in the cancer population, or specifically in the cancer population. So I think that would be a case where we would treat. And distal DVT, we have some guidelines suggesting, distance to the above to the popliteal vein, distal length of the clot. But in the cancer patient, I think, a lot of clinicians would favor anticoagulation, especially if the risk of bleeding is not excessively high. How long do you treat these people for? Do you apply what I said earlier, which is, well, treat them for at least 6 months, reassess. If the cancer is active, another 6 months, reassess, another 6 months, as long as that goes, which could become lifelong anticoagulation. And the problem is that you've had something that, may have been controversial to treat in the first place. Some might not have treated, but here we are committing somebody to lifelong anticoagulation in some cases, which may or may not be necessary. And I think it's a really difficult question. So I would treat, and again, I would reassess I would probably be, incorporating that in my discussion with the patient that, this was not a proximal DVT or an extensive PE, but there is a risk it could happen again because the risk factor is still there. And try to get patient preference into that, because I think that, some patients would say, I really don't want to be on another pill, another treatment during my cancer journey. And some people would say, it's happened once, even though it was small, quote unquote, I don't want another one to happen or a bigger one to happen. Again, if they ask me my opinion, I think it is a case-by-case basis, but I probably would lean towards continuing as long as the cancer is active, but have a kind of a lower threshold to stop. So a little bit of a vague answer, but individualized.
Perfect politician.
Yeah.
I don't think you answered the question.
I would treat, but I don't know how long. How about you?
I would do the same. As you mentioned, there's very little data. I would probably treat with therapeutic dosing for a while. I would sort of feel bad continuing therapeutic dosing long term. You're not really worried about that clot, you're worried about the recurrence. There's a little bit, and we have data now with Avert and Cassini that primary prevention should be considered in patients with high risk of cancer-associated thrombosis. And there's some observational data saying a previous event is similar to a coronary risk score of 3. So just based on that, I think they probably deserve some anticoagulation. They're clearly clotters, and then they probably going to recur, so you want to avoid that. I would, after a 3-month period, I would probably feel comfortable with decreasing it to prophylactic dose, I think. And then one last question, because we have you on the mic and I rarely have the opportunity to ask a question. So what about absorption with the DOAC? So what if you have a certain bariatric surgery or bowel resection? In this particular case, it's Whipple surgery or colectomy. Does that tailor anticoagulation using DOACs for you?
I think it does. I think, depending on what's resected and what their absorption status is, I think this is similar to the drug-drug interaction question. I think in those cases where, there is a concern about absorption, I do rely on my pharmacy colleagues to help me through that, looking up the specifics of the drug and interactions or where it's absorbed, et cetera. But if there is a question, especially in the beginning at the time of diagnosis with a big clot, I would use low molecular heparin to bypass those issues, just for comfort of mind, really. If it's 6 months down the road, they're not having any symptoms from the acute clot, we're using it more for secondary prevention. We feel the risk is much lower than it was when they were diagnosed with cancer or starting chemotherapy. At those points, I think it is a judgment call, with absorption issues and drug-drug interactions. Most of the drug-drug interactions, decrease the efficacy of the anticoagulant. So if the anticoagulant is not as effective, how much of that makes a difference at 6 months compared to quality of life if they are having some distress from the injections or the difficulty with the parenteral medication? So I think I do take it into account, and if I am concerned, I do revert to low molecular heparin. So I committed there, Mark. So I hope you're happy with that.
Very proud of you.
Yes.
So I agree, and as you mentioned, it depends on the timing, right? When was the index event? Are you treating acute clot, or is it for secondary prevention? And we have so many options. So if you're worried about absorption, we don't know if these are clinically relevant or not yet. So if you're worried about it, then patient had bariatric surgery or resection of the proximal small bowel or gastrectomy, avoid rivaroxaban, edoxaban. If it's lower down, like close to the colon, right-sided colectomy, so maybe avoid apixaban. Otherwise, there's other options. So why not use what would not be effective, I guess. Yeah. So Dr. Shivakumar, thank you very much. And thank you very much for attending. And we'll close and start the meeting in 10 minutes.
Thanks, everybody.